What I thought I should do is just to share some of the things that are occurring and perhaps offer some perspectives about what we might need to do to have a much more successfully integrated care system. And as we were talking at our table, I mean, this issue about do we have a need for change was a real debating point for us, because what is the burning platform in our system for change? We all recognise that there are challenges and that things aren't sustainable the way they are, but we had an opportunity for national health reform a few years ago and ended up with pretty much the same. In terms of the healthcare system that we are involved in, it's one of the best healthcare systems in the world, and our communities receive some of the best outcomes. What are the burning platforms? And the thing that's obviously concerning people is the spend and how we get that addressed. And I think the focus at the moment, particularly with the introduction of activity-based funding, the signal there quite clearly is that there's a lot of waste to be cut out of the system first before lots of other things happen, and so a real focus on technical efficiency. We can all argue about whether or not that is going to be at the cost of allocative efficiency and investing in the right place, and I think that's a really good debate for all of us to have. But I think we need to think about, if that's the paradigm we're in, then what are we going to do within that to actually address the issues as we see them? And might offer some points about or thoughts about that as we move through as well. In terms of coming back to the patient, I think it's really important that we come back and are anchored by the patient perspective always. And on Monday I was fortunate enough to be actually in this very room and spending a few hours actually focusing on the importance of the consumer perspective. I still think as a healthcare system, we decide what we are going to do. We redesign the system based on what we think patients' needs are. We don't listen to their concerns, we don't listen to their experiences, and we don't address those barriers and challenges in the system to ensure that we're overcoming them. So how we get there is going to be really important for us all to take hold of. We've had HealthOnes in this state since 2006, and that was an investment, a capital program investment, which was actually about saying that we need to build better facilities for providing primary care and community health, and to get better integration with general practice. Now, I'd say to you, I'm not sure that program has been an outstanding success, except that there are some pockets of excellence, places that have actually grappled that opportunity, taken it to a level which is what we really should be seeing right across the board. I mean, in terms of what focus is on our system, the focus in our system, and having managed in it for the last 25 so years, is all around hospitals. It's all around what happens in hospitals. Here was an opportunity with a capital program that was saying we want to invest in primary and community. Did we actually take it to where we could have taken it? I'd say probably not. Although we have 28 HealthOnes around New South Wales at the moment, some of them are still in the planning stage, but the question is whether or not we have planned adequately at that local level to get the true integration and a model that actually is identifying how we can treat patients and provide patient-centred care in that setting. And to provide an opportunity for a different pathway to access our health system. I think the real problem for us at the moment is, on the public side, the access point is emergency departments primarily. And that's where everyone goes. That's where they know they've got a one-stop shop. They know they can access 24/7. We've got to create different pathways. If we want to change that paradigm, we've got to have different pathways where people can access care and know that they can get holistic care and get comprehensive care at a time that they need it. We've also been involved in implementing the chronic disease management program, and that's now a few years down the track. And while we might all reflect on the way that was implemented and think there's lots to learn out of that, there's been some fantastic improvements as a result of that program being implemented. And enrolling patients who are at the higher end of need, identifying how we can provide better care coordination or case management, ensuring that they're tapped into the services that they need to support their care. And I think around the state that's been implemented in different ways, in higher levels of partnership with Medicare locals. In some places there's been a pooling of some of the resources. There have been staff who've actually worked out of the Medicare locals even though they're employed by the local health districts. They are a good example of what we can build on that example. And I'm seeing increasingly that the relationships at that local level have been strengthened by that initiative, and has been a good starting point for us to do further work. In terms of what's happened, and one of the things that we really have struggled with is about how we can demonstrate the benefit of that program. We've got a very detailed and thorough evaluation underway at the moment, and hopefully we'll get some better information in a couple of months' time. But just to have a look at the impact, we did a study statewide and looked at avoidable hospitalisations pre and post enrolment of the cohort that are in the chronic disease management program. And this is I think we need to be very cautious about this, very early data, but it did show an encouraging trend. The two bars on the left, are the darker bars, are 6 to 12 months prior to enrolment, then 0 to 6 months prior to enrolment, and then the three lighter bars are 0 to 6 months after enrolment, 6 to 12, and then 12 to 18 months after enrolment, looking at avoidable hospitalisations in that cohort and seeing a reduction over time that looks like it's been sustained. Now, I think we need to be really cautious about that. We haven't got a control group there, and we need to wait to the full evaluation, but some encouraging signs about the potential benefits of investments in programs like that. Western New South Wales and Northern New South Wales also did their own local studies into the patient groups that they'd enrolled, and also showed similar changes, with a reduction of 49% in Western New South Wales in that group in terms of avoidable hospitalisations, and then 39% reduction in Northern New South Wales in the cohorts that were assessed. So that was reinforced at the local level as well as replicated at the statewide level when we looked at the data. We know that there are lots of initiatives going on at the local health district level, and I think that the advantage of actually having the local health districts thinking about what they should do with their Medicare locals has been a real strength of our system, and having those relationships at the local level. I know that Central Coast are looking at a total integrated strategy around introducing ComCare in their community-based space, and have partnered with a non-government organisation to help them with that strategy. We've indicated we'd like to be involved in helping support the evaluation of the impact of that change. It could be a very interesting approach that we might learn a lot from. At South East Sydney Local Health District, there's the Diabetes Pilot Project, which is looking around the impact of integrated multidisciplinary teams for diabetes care. We would also say that that's a really interesting piece of work, and would be really important to assess and evaluate the outcomes of that. We're also aware that in the Mid-North Coast, the local health districts there and the Medicare local are looking at a shared governance model around how they can start to plan and provide services in a shared way. So at the local level, there are lots of activities as well which are really important and helping us in the direction of more integrated care. So what have we been doing? And at the ACI, we highlighted that from our point of view, it was really important to start to get into this space. The organisation had come from a base of being clinician and consumer driven, but the clinician and consumers were mostly from hospital-based services, specialty-based care. And one of the things that we highlighted was the importance of starting to involve general practice and primary care into our thinking. So we established a General Practice Advisory Council and have started to have regular discussions. Have also indicated that any of the models of care or frameworks or guidelines that we develop will be run by the GP group, and have them involved hopefully at the outset of the development of those, to ensure that as we develop them they're appropriate to think about across primary, secondary and tertiary care. Most of the work we were doing was focused on secondary and tertiary care and didn't think about primary care at all. So we initiated those steps. And the other things is that we thought we needed to invest in actually supporting getting better integration. So focusing on a few components that we thought would help build towards a better integrated approach to providing care to patients across the system. So the health pathways work we were aware of was going on in a couple of places, and that there'd been good results out of Canterbury. So we thought it would be important to not only evaluate what had been happening in the local health district and Medicare local, Hunter New England and the Hunter Medicare local, that were actively involved and had developed a number of pathways already, get a qualitative and quantitative evaluation of the impact of those pathways. What were they doing? Were they really delivering the benefits that people saw in our context? And also then invest in work around priority areas for us, which came out of the work of our Aged Health Network, which is around getting better integrated care for older persons, particularly those with complex health needs. And the other major focus area that came out of a lot of discussion and concerns from clinician groups right across our system was, how do we get better palliative and end-of-life care in place, and start to think about holistic care as we move towards that end of life, and the fact that we're not doing that at all well, and that people are seeing the consequences of that continual readmission to hospital, people ending up with very active treatment at very end stage, discussions with families, in intensive care unit being the first time any discussion had been had around end of life. So we saw those as really important directions that we could support enablers in ensuring that we're moving towards more integrated care. So a little bit more about those. In addition to doing the evaluation at Hunter New England, we also identified some support for Medicare local and local health district partnerships to actually start to look at how they might introduce health pathways in their context. We felt we needed to do that across a number of sites in the state, just to test how did that work in the New South Wales health system context. So Inner West Medicare Local and Sydney Local Health District went west and Western Sydney, and Central Coast Medicare Local and Local Health Districts are doing some work around health pathways that we're involved in supporting, and will be also involved in evaluating as they get more along that journey. In terms of the benefits, I mean, we hear all the time the benefits out of that health pathways work, which is around the fact that the providers coming together, often with consumers at the local level, and having discussions around how care should be organised to get more patient-centred care. On many occasions, it's the first time that those people have come together to talk about how they organise care at the local level. So the way things are arranged in our system is very much ad hoc and has developed over time, and no one's ever actually planned it. So and even the relationships, people actually meet people for the first time, even though they've worked in the same town for years. So establishing those relationships at the local level and having those discussions about how care should be organised are really important improvements in the system that is very much a bottom-up approach. So we see that as being one of the solutions to support better integration. Just in terms of the qualitative assessment, we did an early assessment with the Hunter Medicare Local and asked 35 GPs, so it's a small sample, but encouragingly 81% of those who surveyed agreed that the health pathways that had been developed in that local context had changed the way they practice clinically. It helped identify ways that they could do things differently. So we see that as a significant enabler potentially, much more that we need to do in terms of building on. 61% agree that they'd change the information they provided to their patients, and 57% agreed it changed the way they made referrals. They're quite significant shifts, but very much a small sample to start with. The challenge is going to be about how we get those changes implemented more broadly and see that we get a significant shift. The larger doses that I think Kathy talked about earlier. Integrated care for the older person with complex health needs, again, a really important focus area and one that we see is going to be critical. And we've done a lot of work in starting to have discussions with patients and their families and carers around what needs to change in our system. We've done a diagnostic report, looked at solution design, and we've got a framework, a draft that we developed late last year that we're getting feedback on at the moment. It's a real challenge amongst even all of the providers to agree on what the approach should be and where the focus should be. And I think it's very threatening in our system, and we talked about some of the power shifts that need to occur. We're still very much driven by providers. What the providers want, particularly specialist doctors and other clinicians in our system, identifying that if changes are going to occur that threaten what they do and how they do it, unless it works for them, they're not going to buy into it. If they feel at all threatened, they won't buy into it. And even in the chronic disease program that I talked about earlier, some of the greatest challenges have been not just getting integration with general practice in our community-based services on the public health system side, but addressing and challenging some of the specialist programs that have been in place to support specific patient groups around their chronic disease management. And our specialists feel very threatened in some places by that shift and don't believe that anyone can care for their patients as well as they do. So it comes out of a sense of control, I think, and a belief system that only we can do the best for our patients. So real issues around trust and confidence, and comes back to culture and some of the discussions around culture that we talked about earlier as well. I won't go through all of this in detail, but this is just talking about the framework we've adopted, and it's a little bit like the house upside down, isn't it? That was presented by Martin earlier. But it basically comes down to designing the system principles, what are the components of care that need to be provided across the journey, and then what do we need to do for each of the different groups, engaging older people and carers, sharing processes, guidelines and tools, and aligning policy and supportive resources and incentives. And it's about addressing a number of things at the same time to see the system change. And I think for me the message there is in integrated care, it's not going to be one thing alone that does this. It's going to be a range of strategies that are implemented that are aligned with the same direction. In relation to palliative and end-of-life care, major issues there for us, and we've been really listening to people around what their experiences have been, and listening to the providers about some of the challenges that they have in providing good end-of-life care and palliative care. We still have a system that is focused on cure, and we see that if we aren't able to cure somebody, then we've failed. And at that point in time, we hear from many of our service providers, our specialist teams in the hospital setting is, well, I can do no more for those patients, so I need to transfer their care to somebody else. And I think that's a big issue for us as a system, recognition that death is not failure of our system. It's actually death is part of the care that we provide, and it's an endpoint for all of us at some stage, and that everybody who's involved in providing healthcare needs to be thoughtful about that point and what their involvement will be in supporting people as they get to that point. Really interesting diagnostic findings. We found that the patterns of care at the end of life and in the last 12 months still very much focused around maximising acute medicine focus. Lots of readmissions to hospital. The length of stay for those patients are longer, their readmissions are high. When we quantified the impact in terms of bed day costs around our hospitals, I think it equated to around a 600-bed hospital in our system and nearly $1 billion in operating costs for the care of those patients in the last 12 months of their life. Now, when the response we get from clinicians is to say, well, that would be great, but we can't identify the last 12 months of a patient's life. If we could anticipate that they're going to die in 12 months and predict that, we could maybe have other pathways of care. I'd suggest that it's actually a paradigm shift, that perhaps the thinking about acute medicine and right till the end acute care is what we need to change. And that we've actually got other pathways for supportive care. We have discussions with patients, their families and carers, and talk about what options there are available, and that not always is it about acute medicine. So we have followed with interest, the literature around the world. The Nuffield, the King's Fund, and the work out of the UK really has been guiding for us. And when you look at the King's Fund, they've published around making integrated care happen at scale and pace, and many of you probably have seen this publication. But in terms of the 16 lessons that they're sharing from their experience, there's not one thing. As you can see, there's a range of things that need to be put in place. And many of them we've talked about during the course of this morning and in the table sessions. But there's no doubt that we need to enable both bottom-up and top-down approaches, that we need to create a very clear vision and direction for where we want to go with integrated care, but enable people at the local level to contextualise that, because it's not going to be the same approach in every place. And in fact, the way services are configured, the workforce that's available, the relationships at each place need to be worked through, and that's one of the benefits we see out of the Health Pathways work. It does contextualise a direction to the local settings of care. But we need to reinforce that with a whole range of things. I think one of the things that we see as a major impact is sharing of information. You've talked about that. But it's also about data on which we can actually assess the patterns of care and whether or not the systems that we put in place do change the patterns of care. We've got real gaps at the moment in our system. We've got lots of information around what happens in hospitals and in emergency departments. We're increasingly starting to see information about what happens in outpatients, but we don't have a lot of information about what happens in the community settings, not on the public health side. And when you look at what happens in general practice, we still can't get MBS and PBS data out of the Commonwealth with which we can assess what's actually currently happening, and then look at what any of the impacts that we have, whether or not they actually address the issues we're looking to address. So they're really important areas. We've got to get better data in which to plan and to monitor. But we also need to get better information about outcomes, and we had to talk about this at our table as well. We don't have any outcomes. We don't agree on the outcomes of care. We don't measure those. We don't report those back to clinical teams and treating teams. And we don't monitor those to see whether or not the outcomes that we wish to see are there. So there needs to be further investment in those areas and agreement about sharing. So those data and measurable objectives are really important as well. And I think the other major area, and I'm pleased to see Mike Walsh from HealthShare and eHealth is here today as well, is about the ICT and getting that integration. But I think we've made some steps in that direction. We've got some good building blocks in place, but there are still some major gaps that we need to address those, and we need to get real information being able to share across those boundaries of care. So really important that we start to think about those lessons and experiences, not only from what we've done, but what's been happening in other places, and develop a strategy around what we might do differently as a result. I want to come back to the point, though, that it's got to be around person-centred. And everywhere, when you see the literature around this, the best care is actually where there are systems that support an emphasis on prevention. We've heard about that, and maybe we haven't focused enough on that during the course of the discussion. That we provide opportunities to give people information which they can better manage their own conditions and be supported to do that appropriately. And yesterday I was at the launch of some resources that we prepared around chronic pain. And a lot of those resources have actually been targeted towards people living with chronic pain, about what they can do to manage their condition better themselves and provide that support in a web-based application that gives them much greater information and power to actually look after their own process and disease that they're living with, as well as then be supported appropriately by general practitioners with greater information in the primary care setting, and then finally being backed up by specialist services, the chronic pain services that exist that are highly specialised teams. Getting that alignment and having a coherent strategy around what you do for different groups of patients, I think, is the future as well. So these are the directions we need to go, and I suppose there is no magic bullet from our point of view. A range of things need to be put in place, a number of enablers that we see a role in supporting. But at the end of the day, it's about having people at the local level being supported to make the difference and make those changes in the way care is delivered, with a focus on their patients and ensuring that the outcomes are improved as a result. Thank you, and I think there's enough time, hopefully, to have some questions.
So, just let's ask a fundamental question. You sit in the ministry, and you...
I don't sit in the ministry.
You don't sit in the Department of... I get confused between the New South Wales...
So we sit a little bit outside the ministry, so that might help clarify things. So we're a statutory health authority, like the local health districts. We've got our own board,
right? And
we have what's called a service compact instead of a service agreement, where we're actually contracted to provide services for the New South Wales health system.
So the boys stood on the burning deck. We've got an unsustainable system. It's all appalling. We're treating people in inappropriate places in hospitals, can't afford it. It's all terrible. Tell me why then, when a CEO of an LHD reduces demand, he loses budget?
That doesn't happen.
Sorry, it does.
Where's the example of where it's happened?
I can't tell you what the example is but I was sharing it. But you've got an LHD who's reduced ED presentations by 4%, avoidable hospital admissions by 9%, and as a result is losing $17 million in the budget, and is saying, why do I do this? Because under activity-based funding, I lose money.
Could I suggest that you might need to get that fact clarified? I mean, every one of our local health districts in the last year actually got growth funds. They may not have got as much in growth funds as they would have liked, but they received a higher budget. There were adjustments made on the basis of some of those factors, there's no doubt, so they may not have got as much growth funds.
But why wouldn't you be... I mean, you talk about simple solutions. You've got a really good framework there, but it's very complicated. Here's something simple, which they tend to do in Victoria, is you do well, you'll gain share, and you can reinvest in other stuff, rather than we'll take your money away because you're actually got low activity on your ED and avoidable hospital admissions, and we'll take that money away, rather than saying we're going to empower you at a local level, because that's probably the simplest thing that we could do to get integrated care. We're going to tell you you're going to be judged in integrated care, and you can use those savings for that in the way that you see fit, and the money disappears.
So I think the point you're making, which I think is an important one, is that our focus is around rewarding activity and growth in activity, particularly in the hospital settings. And I would completely agree that we've got to reorient our system away from that as an approach. One of the problems I think we have, and having managed the local health district equivalent for a number of years, we don't have good information about what happens outside of hospitals. So we haven't even counted what happens in community settings, and we haven't focused on it. We haven't counted what happens in outpatient settings. We haven't costed it well. I think we've got to have the same approach to what goes on outside of hospitals as we have as to what goes on inside them. And the approach needs to be that we can have a discussion, because at the moment, while that's invisible to managers and funders, they're very loath to say, well, we'll just put more money because we don't know where it's going. And I think this drive towards activity-based funding is an opportunity for us to actually to accurately count and cost work everywhere and then argue for why the shifts need to occur in the investment.
So, but when you go, I'm just trying to simplify the issue and get, so when you go around and sit and talk you talk around the place, they'll say, talk to Medicare locals, they say, well, I'm sitting here, we've got duplicated services because the LHD is actually doing community-based services. Why is the LHD doing it? Well, some of the time it's just because I can press the button and make it happen and I don't have to go through another sort of bureaucracy and negotiate with it, so I can make it happen. You can understand that. But it's also that I get beaten up on a daily basis as an LHD about my waiting lists, my NEAT targets and NEST targets or whatever else. And that's what drives me. And you heard Peter Gonski there talking, and others talking about, if you actually shift this frame of focus to the community, to the patient, where most of healthcare occurs, the incentive in the system focuses on the hospital. So I suppose I'm saying you've created a nice framework, spent a lot of time doing it, when in fact the incentives could create the change very quickly.
Well, I think my point was that there needs to be a number of things that need to change to align to see that thing. And I agree, the frameworks alone will not do it. We need to get a number of other enablers. IT improved and better connected. We need to get the financial incentives in the right place. But we need better information. I think the concern people have at the moment is there's not enough information at what goes on outside, and I think we're really struggling with that. And we can't get MBS and PBS, and we can't see the patterns of care in general practice. Well, we don't know what we're doing in our own community-based services very well. I think there's a real risk that people are worried about, trying to get that shift when they don't even know what's going on there at the moment. So I think it's important that we do identify what's happening in those places and argue for the very things that you're outlining.
So give me a flavour of how you're trying to solve that problem, because you're stymied in a sense, because the evaluation loop is, you've only got half the evaluation loop. Do you just sit and wait until Canberra or RMAC comes together and says, yes, we'll give you LGA, MBS data?
No. So that's why we've actually supported work at the local level. What is the Medicare locals can get access to that information for their own Medicare local.
They can't get it by LGA.
They can get it for some of their, but at least at the population level of the Medicare local, they've got some information. So what we're saying is let's support the move towards that occurring while we push for all of those other things to be put in place. But let's do what we can within the system at the moment to start getting the direction. The health pathways work is an example, the integrated care work that we're supporting at Central Coast. I think that you've got to move and make things happen within the things that you can have control over rather than wait for others, because waiting might mean that nothing ever happens.
So I should correct myself there, not LGA, SLA. But what I'm hearing from CEOs is that they don't feel they've got the freedom to shift resources to do what Jerry's talking about. So Jerry might be talking as a new boy on the block here, and he hasn't yet confronted a conversation at Miller Street in the Star Chamber. But they don't feel they've got the freedom to shift those resources out into the community and change things, because they're on this treadmill, and so they make an efficiency, and then they get mugged around the corner rather than saying we'll downscale that and reinvest so that in fact the system becomes sustainable.
I think that CEs have a real opportunity in the process of discussing what their service agreements will include for the next 12 months to actually put a case. If they had a strategy which had enough around it that gave people confidence that that was likely to occur, I'm sure they could negotiate with the ministry to have in their service agreements an appropriate level of resources to do and make that shift. I'd challenge the district CEs to give it a crack and see what response they got. And I'd be very happy to support it from the ACI point of view.